I can't really tell if there's anyone else who needs to be here.
I think that you are good to go with it, being 9:01.
Okay,
Thanks, Cheryl.
great. Thank you, Katie. So I first want to welcome you to the second leg of the journey to our ultimate deliverable of producing a unified financing strategy for the Universal Health Plan. Thanks for joining us again and for your commitment to this committee. Today, our focus is on health spending. And so I first want to acknowledge some written public comment. Had some very thoughtful comments from Tom Sinsick pointing out another healthcare expense that's often overlooked, and that is insurance for college students. And some of us have been there with our college students, so that's a really good catch. And Charlie Swanson sent a multi-page public comment with lots of good suggestions and questions on baseline healthcare spending data. We're going to dig into that today, and just want to thank you, Charlie, for your extra work. I had to read that a few times to digest it. So now I'm going to turn it over to Katie to do the tech check.
Thank you, Cheryl. Just a reminder for everyone, just keep your video on if you're able, so that people can know that you're a committee member. Keep yourself muted unless you would like to speak. And in that case, please just use the raise your hand function. And then just a reminder that members of the public are joining and able to view and listen. They just can't have their screens and their audio on, but just be aware that they're here, and that that's why it's important to keep your camera on if you can. And if you have any technical issues ever at any point, please don't hesitate to reach out and we can get those resolved.
Thanks, Katie. And now we'll do an icebreaker, a seasonal icebreaker question with roll call. I'll hand that over to Katie.
Great, thank you so much. So the seasonal question today is, what is your favorite Thanksgiving food? So when I call on your name, please just unmute yourself, share your name and your favorite Thanksgiving food. And we will start with Cheryl Ramirez.
Yes, thanks, Cheryl Ramirez. And I can't go without the cranberries.
Thank you, Cheryl. Samantha DuPont.
Hi, I'm present, and I would say if I could only pick one, stuffing with lots of gravy.
Richard Gibson.
Present, and I'm a big fan of cranberries as well.
Jeff Goodman.
Good morning, present, reflecting my mother's Norwegian heritage, pickled herring along with the turkey.
Oh, wow. Nice. John Santa.
John Santa here. Whatever the dessert is.
Charlie Swanson.
Turkey. I'm here, and turkey with cranberries on top.
Seeing Bethany Stairs and Chris Hogan, but I will just keep an eye out for them as they join. And I'll turn it back over to you, Cheryl.
Thank you. I'm just going to do a quick agenda review. And so today, as I mentioned, we're focusing on health spending in Oregon and considering sources from past studies, as well as identifying other sources of current health spending. So we did the welcome and all of that. We're going to first review feedback that we received at the last meeting, as well as in between the two meetings. We received lots and lots of feedback, which I really appreciate. And let's see, and then we'll hear a presentation on health spending in Oregon as a starting point, and then we'll develop a revenue guiding document. And I forgot one thing. We're going to go over one more time the values and principles just to make sure we're set. And we're also going to go through the work plan, not just for finance and revenue, but for the other committees as well, as there could be a little overlap. So go head to the next slide. Okay, so you've seen this before. This is our committee timeline, and here we are in November at the update health spending meeting. So that's where we are. Next slide. So we're gonna review some feedback. Like I said, we've received lots of feedback during and after the meeting. And many of your comments we are using to shape future agendas. I'm particularly grateful to Morgan that she arranged your feedback into categories, comments that fit within the scope of the Finance and Revenue Committee, and those suggestions that are outside of the charge of the committee and belong within the scope of another committee. So based on the feedback, we want to spend a little more time during this committee meeting reviewing the board approved work plan. Not only the parameters of the Finance and Revenue Committee, as I mentioned, but especially the plan, design, and operations committees as well, so that we don't overlap and duplicate work. We've all got enough to do. So in addition to this feedback that has been categorized on these two slides, we had a couple of suggestions on overall approach and specifics on the attributes document, which we're going to get to a little bit later. So as you can see, that these are Finance and Revenue Committee specific feedback and economic analysis. It's in our work plan. Healthcare expenditure spending. We need to update those numbers, and that is the focus of today's meeting, as I've mentioned. Medicaid match rate differentials will be a discussion topic. The concern about the moving target of building budget. It's our role in this committee to build the budget first. So we're drafting the budget and may need to tweak the budget depending on what plan and design come up with too, and on what we find out about revenue. Administrative savings assumptions is a future topic. I don't remember which month that is, but it's on that timeline, and reserves needed is also on that timeline. Like I said, we had a few comments about revenue principles, attributes, that equity should be front and center of this work, that potentially we could morph together the principles and the attributes into one document, and whether we have resources to do everything included in the attributes document. I think my short answer is probably not. So next slide. And as we mentioned, there were several comments that fit more in the parameters of plan, design, and expenditure committee. So on reimbursement, plan, design, work timeline, and again, we're going to look at that a little bit more when we look at the work plan, so you can see what the plan design committee is tasked with doing. Plan design modeling. There were some detailed questions on Optimus numbers, actuarial analysis needed, hearing from a country that uses global budgets, assumption of services being provided. This is all plan design and expenditure committee work. There was a question or comment on the transitions and operation timeline about the committee, the timeline and process for implementation. So that's under their purview. And then last, we talked some about using a calculator for individuals to understand changes and for providers to show changes, scenarios, things like that. And of course, that's a great idea. It's just not something we can do right now at the get-go because we're not far enough along. So next slide. So we're going to review the board adopted work plan, and I'm going to turn this over to Morgan.
Thanks, Cheryl. I think it was really helpful receiving all of that feedback. And as Cheryl just went through, some of that feedback was kind of in the scope of the assignments for finance and revenue, and some of them were outside of the scope of finance and revenue. So we thought it would be a good idea to spend a minute kind of looking at the overall work plan for that the board adopted for all of the different committees, so that this committee would understand kind of the overall plan. We didn't do this at the last meeting. We really focused on the kind of scope for finance and revenue. So based on the feedback, we thought we'd take a couple minutes just to look at what the other committees are doing and how the committees will kind of work together. Next slide, please. So the board adopted a work plan that has 3 different phases. Phase 1 is really kind of on focusing on the board and getting the board up to speed on the topics, getting the structure of the committees and everything set forward. So you'll see that top governance board timeline. Really, the only thing that's on here for what the governance board is doing is really those annual reports, status reports to the legislature on the progress. This timeline really focuses on phase 2, which is that proposal development. The board approved a plan that has 6 work streams. And they've kind of been grouped into committees. So work stream 1 and 2, community engagement and communications, are grouped into one committee, the Community Engagement and Communications Committee. And that committee has already started working and is really responsible for that targeted engagement with interested parties that the bill calls out. So in Senate Bill 1089, there's a focus on engagement with business, on engagement with the healthcare community. And so really that community engagement strategies will be really focused on meeting the deliverables in Senate Bill 1089 and will be responsible for a lot of that work that this committee will do in coming up with that financing structure, and then community engagement will help do the engagement with those interested parties. So work stream 3 we'll talk about in more depth and continue to talk about, and you all, we talked about this at the last meeting, so I'll come back to that one, but a lot of the comments that we did receive were really around plan design and expenditure. And the way that the board built this work plan is to start with the finance and revenue work to come up with that cost target and revenue plan for how to fund it and how much like an annual spend would look. And then the plan design will build the plan to fit within that. In July, we'll have a meeting of finance and revenue and plan design where we'll look at the two and see like, here's the budget and revenue plan, and here's what the preliminary structure is. And finance and revenue and plan design will have to come up with a strategy. Do we need more revenue, or do we need to make plan design changes, or do we need less revenue and plan design changes? So those 2 committees will come up with that together. And then operations, a lot of what Senate Bill 1089 really focused on wanting to make sure that there was the administrative structure, the public corporation, statutory authorities, public trust, IT systems that were needed to operate a universal health plan. And then, of course, once we figure out the financing and the plan and how the structure will look, we would need a transition plan to figure out how to phase that in. And that is the one committee that the board has not yet appointed members to. It will be kind of the final phase of work after we have enough of the other work streams figured out. Next slide. So I pulled this up just so you could see the deliverables for plan design in particular. So plan design will be coming up with those final recommendations on the universal health plan benefits plans, eligibility, provider reimbursement, look at workforce and cost containment strategy, and will be the place where that the committee that will work with the actuarial analysis of that plan. So again, the focus of finance and revenue is developing that unified financing strategy that could fund the plan. I'm going to pause there. Any questions about kind of the work that's in finance and revenue and the work that's in plan design? John.
I was a little concerned to read and can survive an ERISA challenge and has support from large and small employers. The ERISA topic is a very complex one. I think the task force, we learned a lot on the task force about it. And so one of my questions is, So are we going to dig into ERISA? The second one I think is probably more important, support from large and small employers. I would just urge, really what we learned at the task force was the first group of employers is public employers. And those are accessible, PEB, OEB, the counties, etc. Now, I'm not sure whether we're going to engage with those large employers or someone else. I think certainly I would hope that we're at least there to listen to that engagement. But I think a meaningful engagement with PERS and OEB especially would be so important because they have data, they have information that I think could be extremely helpful.
Thank you, John. The way we're looking at the work plan right now is that the finance and revenue would come up with the financing strategy and revenue plan, and then the community engagement committee would be responsible for a lot of that engagement. But I think that's a great suggestion, and we'll make sure to let you know when and how that engagement will be happening so that you can attend. I think that's the connection between the committees that we're really wanting to make sure we're facilitating. Jeff.
Good morning again. Thank you. I listened to and watched the design meeting from about a week and a half ago. And one of the things that came through very clearly is that there is a pretty good framework of an existing plan to provide the, if you will, universal coverage. I think it would be helpful for us to just have the opportunity to see what is that framework and what is the estimated cost of that framework. I think that will help assist us in designing whatever kind of financing plan we come up with, if we have at least some idea of what a draft project looks like. And that would be part of the iterative process that we'll go through.
Thanks, Jeff. We'll get into this a little bit later too, but the way that this the finance and revenue is going to work in developing the budget, we've got a proposed strategy that we'll go into. And I really appreciate that you're attending the plan design. That's great to help facilitate the communication between the committees. Helen.
Hi, everyone. I'm Helen Belanca. I'm the chair of the Universal Health Plan Governance Board. I'm not an official member of this committee, but I'm just listening in. And I first want to thank Cheryl for stepping in as chair of the committee and helping to guide this work. I was hoping to just underscore a few things that that Morgan was saying. I know this is a little bit confusing. This task that we've been given to come up with a universal health plan and figure out how to pay for it is enormous. It's just a huge problem, right? And so one of the strategies the board is using is to try and divvy the work up among these 4 committees. Jeff is absolutely right that, you know, we have a preliminary structure of what the plan looks like. And John is absolutely right that we've got to engage the business community, and it's sort of a lot. So dividing it into, like, we've got one group working on what the plan looks like. We've got a group working on the operations piece. We have a whole community engagement committee whose job it is to reach out to the business community. And yes, the public employers is a great place to start. We're trying to divvy it up just to kind of break down this enormous task in a reasonable way. We know that this separation of the work into committees is a bit artificial. All of the committees are going to depend on each other's work. There's just no way that finance and revenue can do their work without really understanding what the plan design is like or what the engagement's going to be like. We get that. And like Morgan said, we're trying to figure out, like, what's the best way for committees to talk to each other as we go along. But that said, what we really need from Finance and Revenue Committee is a revenue structure and a revenue plan. Yes, of course, like you need to know what you're covering, but in the past, when these efforts have been tried in other states and elsewhere, kind of the way it goes is somebody builds a really cool plan. Let's provide X, Y, and Z for all the members of our state. And then they say, okay, great. How much will that cost? It's going to cost this much. Okay, how are we going to pay for it? We're going to pay for it using this, these revenue streams. And then you get to that part of revenue and it's like, wow, that is way too high. Those taxes are way too high. That's just not feasible. It's not going to work. And so we spend all this time building this plan and kind of creating everything that it's going to look like and all of these strategies. And then when we get to the revenue part, it doesn't pan out. We can't make the revenue match the plan. So I know it's a little bit, we're trying to do it a little bit differently with this. What we want this group to do is first come up with a revenue structure of something that's feasible. And then we're going to take that revenue structure and try and adapt it to the plan design, or try and adapt the plan design to the revenue. So basically what we want this group to really focus on first, your first priority is understand the world of like, where does all the money in our health system come from? It comes from the feds and comes from the state. It comes from employers. It comes from individuals and families and households, right? So if we took that pot of money and if we said, we want to pay for some plan, which we don't know the full details of the design yet, but we want to know how we could come up with that revenue if we said that that individuals and households are not paying premiums and copays, that there are no out-of-pocket costs for the consumer. So what would be a revenue strategy to come up with that money? Like how would you structure it? What would come from feds? What would come from the state? What would come from taxes to businesses or taxes to households that would cover that revenue structure? We just want the structure. And as Morgan says, like we'll kind of put a dollar amount on it at some point. But what is a realistic, feasible revenue structure that could work, that would sort of be feasible and sustainable? And then once we have that, we have the basics of the plan design and we can sort out the details of like who will pay for what. But you're not going to know, sort of all the details of the plan. We just want to know a feasible revenue structure and kind of a rough dollar amount. And then we're going to work from there and do a little bit of back and forth. So really that is what we're hoping this committee will focus their work on is that revenue structure. And then we'll take it from there.
Thanks, Helen. And we have a visual that is in a couple slides that after Charlie speaks, we can jump to kind of walk through. Charlie.
So I want to say that the first task of finance and revenue before we get into a revenue structure is to figure out what current healthcare spending is. And so at some point, we actually need to address that topic and try to get the appropriate data that we can from OHA and from DCBS and from SAFE and from the counties and from any other entity that hopefully we can get to cooperate with us. So I just want to put that out there.
And the presentation from HMA today has has an overview of spending and then some discussion to talk about at the end and questions throughout.
I would just say, as I pointed out in my thing, is that it's very clear that the overview from HMA is extraordinarily incomplete. And so I just want to put out that that's what my public comment was essentially about.
Thanks, Charlie.
Yeah, and I just want to say you'll have the opportunity to make comments, ask questions. I thought you posed some really good questions in your public comment, and we'll have time for that during the presentation.
Great. Well, moving back to the slides, let's jump forward a couple slides. I think the next slide is the objective, which we've covered. The charter deliverables, this financing strategy, and then can you go back one? The other major deliverable is the analysis of the impact on the universal health plan on Oregon's economy. And of course, before we do that, we need to know the financing structure, we need to know the plan. So that will be kind of one of the deliverables of this committee that is farther down the road. But we'll be focusing on that first, on that financing strategy first. Next slide. So here are the tasks that are in the work plan that the board adopted. And I've been putting these kind of in my mind into a phase 1 and phase 2, kind of thinking that the list of attributes, the review and understand current health spending that we'll be talking about today, developing an annual universal health plan cost target that can be supported with new revenue and existing health spending. And review the methods of revenue collection, and then, of course, review, update, and build on the revenue options. That's kind of all tasks that are in this first phase of developing that financing strategy. And then we'll get some support and from community engagement around the engagement with large and small businesses. And then we will have a second phase of the work that will be describing the impact of the revenue. Once we have that revenue financing strategy, then once we know that revenue financing strategy, we'll talk about plan reserves and strategies for building those reserves and doing that kind of compare and contrast. So first the committee needs to develop that financing strategy and then kind of figure out the all of the tasks. Next slide, please. So here is a visual to try and kind of put into steps what Helen just explained, kind of in the overall strategy. And it says budget here, but really it's that is a term for that revenue plan, that a cost target, building the revenue plan, kind of thinking about it. So first step, review the current health spending. How much do we, as a, everybody who's spending money, spend in Oregon? And then identify the sources that are used to pay for the health spending, and which of those sources we believe can be transitioned, which assumptions can we make? We'll need to estimate the administrative savings in a universal health plan. And then we'll need to identify revenue sources. We have the Joint Task Force work on their revenue sources, but maybe we can look at additional revenue sources that the committee might want to think about, and then develop those revenue parameters. How much, who would be taxed, and kind of figure out an overall budget that includes the current and new revenue, and recommend that to the governance board. So that's kind of like an overview of that first phase and kind of step-by-step process. Next slide. Cheryl, I'll turn this back over to you. This is something the board's been talking about.
Yeah, thanks, Morgan. I found this linear graphic of the process helpful for me to understand the role of the committee and the interplay with the board. So we thought it would be useful to quickly review. So let's take the big deliverable of the unified financing strategy as an example. We receive the information we need to make a well-informed straw proposal to test with the board. And then we move it to the board. The board may accept it, or if it rejects our proposal, then we'll refine based on board feedback. There's then a financial economic analysis, and based on those results, the committee may need to further refine the proposal, going through this process with the board again. And then finally, the proposal is approved by the board and included in the plan to the legislature. So next slide. We're going to just go over the adopted values and principles by the board one more time. Could you go to the next slide? So there was a comment about centering our work in health equity, and as you can see, one of the first overarching principle that the board adopted is health equity as the priority, along with maximizing health, fair distribution of medical resources, minimizing financial hardship, and ensuring a community sense of ownership and governance. So those were 5 of the principles that we had already adopted. Next slide. We also clarified or went into more detail on priorities and criteria for meaningful public participation. That was adopted on August 15th. And we talked a little bit about our community engagement committee and how that's going to work, making sure that we hear a variety of voices in our communities. And we also clarified targeted universalism, that is that there will be different strategies to achieve the universal healthcare goals based on how groups are situated within system structures, cultures, and geography. So we felt like we needed to put a finer point on what that means. Any questions about either the principles that we adopted or these particular details on this slide? Okay, with that, we're going to get to the review of health spending in Oregon. I purposely went kind of speedy quick through some of those, the earlier agenda items so we could spend more time on this and allow for, well, there are 2 times of discussion. I can't remember which slides they're on exactly, but we'll have a chance to discuss midway through and then at the end. But I do want to encourage you, if you have a specific comment or question on a particular slide, to go ahead and raise your hand, and I'll help watch for hands raised so that you can just make the comment right then. And so it may take us a little bit longer to get through this part of the agenda, but I think it's important. So with that, Janine Smith from Health Management Associates is going to review the current health spending. The goal today will be to identify the total health spending as a starting point for building the universal health plan budget. And we'll also start discussing sources of funding that can be transitioned to a universal health plan. So Janine, take it away.
Thanks, Cheryl. Good morning. I'm Janine Smith. I'm also accompanied on Magically in Outer Space is my colleague Anya Rader Wallach, calling in from Vermont, Rhode Island area. We were asked to pull together the most as current of health spending as we could. We are not actuaries. We are not data gurus like our HMA partners, the Wakely Group and others. But we wanted to try to bring to you the most current data that we could find, that the healthcare system here in Oregon actually is being held accountable for at this point due to the cost growth program. It represents what is being spent by other health plans, programs available to Oregonians currently that would be replaced by the universal health plan eventually. Oregon is pretty unique across the country. There are only 8 states that have started to look at expenditures and cost growth in their states, and Oregon is a premier leader, along with Massachusetts and Rhode Island and a very small group of others, to actually collect the data and have mandatory reporting. So the bulk of the data that you'll be seeing comes from the Sustainable Cost Growth Program. There are 30 payers that they collect data for. There's an 88-page document that describes how and what they need to submit. So, and it includes the individual market, the small group market, both on and off of the health insurance exchange, the large group market, short-term plans, student plans and associations, trusts, and MIWAs, otherwise known as multiple employee trusts. It does not have, those are all the mandatory reporters, and that's where this data is coming from. There are some lines that they're not required to be submitted, such as workers' comp and disability and a handful of others. And self-insured is purely voluntary due to the ERISA challenges there to mandatorily request that information. So as you go into this data, just you have this unique opportunity that was not available when RAND and Optimus started to look for data. that was not available then. But since the cost growth program has started, there is this data of what is actually being paid to providers to provide care to Oregonians currently. So with that, I'll move to the first slide. Next slide. And as Cheryl went through, we are focusing on these first two parts of our arrow. Next slide. So it's complicated, the system of how we pay, as you all are very well aware. And it comes from ultimately, everything really comes from the residents of Oregon, but goes through a variety of paths in order to get to the healthcare providers and in order to provide us with the care and services that we get. Next slide. In theory, the new health plan, the universal health plan, should greatly simplify things. This is just a rendering of what you would hope would get a much more simplified system here in Oregon. Next slide. But by simplifying it, there may be some revenue streams that will or might be eliminated, and those are some of the things that this group will need to be talking about as you restructure. Next slide. So the key takeaways from the data that we found to present to you is to kind of give you a brief overview of what the past two studies tried to accomplish, just so you know where you're starting from. And then the most current data, and we'll go through all of this in more detail of what is being spent per the collected mandatory data to the state, and that the current system is being financed through a mix of household, employer, state, and federal funding. So next slide. So previous studies, just real brief snapshots, just to remind everyone. Next slide. The RAND report, which actually I was part of the team that worked with RAND on this, and there was 3 models in addition to the status quo, and the single payer was one of the plans that was compared. At that point, and it was old data, it was approximately 6,610 per year was developed as what was used for modeling. There was some adjustments and offsets, as you've also seen later in the Optimus report, and has been done in other states when they have looked at universal, of that you'd have increased demand because you'd have lower cost sharing and full coverage, and the adjustments in payer rates as you try to unify your payer rate. The sources in the RAND assumed Medicaid match from the feds, a means of getting the premium tax credit and cost sharing reduction federal dollars from the marketplace, federal outlays for Medicare, and then the health benefits for federal workers, veterans, and other federal programs was included in their version of the single payer, as well as the state funding, and then new state revenue pulling primarily from income tax and employer payroll tax for larger, at least greater than 20 workers. The CBIZ Optimus report also evaluated just the single payer that was designed by the task force. It used 2019 data sources projected to 2026. Again, they did not have the cost growth program in place at this time, so they did extrapolate from a variety of sources, including the national data sources. The 2026 expenditures were estimated to be around 54.6 billion, with an expected 4.4 million enrolled. The savings was calculated at just under $1 billion. And again, they assumed that the financing sources that could be moved forward for their revenue strategy was the premiums for Part B and D, and from individuals and employees, federal funding from Medicaid match, the marketplace, and outlays for Medicare, state funding, and a household income tax and a payroll tax. So just to keep in mind. So both used the most available data they could at that time, extrapolated or trended costs forward, and then adjusted for impacts. They assumed all Oregonians, including those in Medicare and Medicaid and undocumented immigrants. And the revenue gaps were filled with somewhat similar approaches, payroll and income tax. The RAND study, the benefit package was different. It wasn't PEB. It was essential health benefits without vision and dental, and there was some cost sharing. This Optimus, which many of you know very well, used PEB with vision and dental, no cost sharing. It included some charity care expenditures, behavioral health, non-Medicaid, non-claims expenditures, and removed the military lines of expenditures, Department of Defense, Veterans Affairs. So next slide. So the next two slides are going to talk about total healthcare expenditures. These are terms from the majority of the data being shown will be from the sustainable cost growth, from that mandatory reporting by our payers in our that provide care, that pay providers in our state. It's got claims, non-claims, and the net cost of private health insurance. It's the cost of administering the health insurance plan, and then other spending, as you will see.
And it looks like we do have a couple questions, starting with
Okay.
Jeff.
Yes, Jeff?
You bet. Thank you. Perhaps I'm reading this wrong, or it's just a typo on the page with the Optimus report. It has the estimated savings versus the status quo of 977 billion. I think you meant million.
I said it was just almost $1 billion.
Oh, well, the page says billion.
Estimated savings versus status quo is 977 million.
I
Yeah,
think
so-
that typo is corrected, Jeff, because on the version that we're seeing in front of us, it's million.
Oh, my apology. I'm looking
Yeah.
at the one on my.
Yeah, that's what I
Okay.
think happened.
And then my second question, which relates to that, is that a net number or a gross number? Because we're talking about the ups versus the downs of the plan that was talked about, with the ups being the increased demand, the downs being lower provider payments and lower administrative costs. So is that 977 million a net or a gross?
A net.
It is net. Thank you.
Yeah. And Charlie, I think you had your hand up as well.
Yeah, related to the next slide, I just wanted to make sure that people understand that the use of the word total healthcare expenditures on that slide, the one that she was on at the point where I put up the question, is not what other people would say as total healthcare expenditures, because it doesn't include public health. It doesn't include expenditures on structures and equipment. That's the biggest ones that it doesn't include. So it's really just personal healthcare expenditures plus net cost of insurance, but it's not even clear if it includes net cost of federal of public programs. So it's not the typical usage of the word.
It's the definition of that was pulled from the growth program, and it was the it is describing the what the expenses incurred by Oregonians and that the payers have paid out. So
Yeah, and I just want to make sure people understand that that's
yes.
not
So if
everything.
you're thinking
Yeah.
about a plan and what would a universal plan need to cover, these were the expenditures. Since
And I will disagree with that, because we're hoping that our plan would also cover costs of structures and equipment. And then I would argue, and I made this argument a number of times, that public health is important to think about anyway. We don't necessarily need to include it, but it is extraordinarily difficult to separate public health and personal health, especially with a good system, especially with a potential RFK Jr. as head of CMS. So.
are there other questions at this point? We'll move on.
Dean, I just want to mention that public health is being discussed in plan design and expenditures. That is, how much to incorporate public health services. So I think that is an ongoing discussion. So we'll have
Yeah.
to confer with that committee back and forth.
And I will say that in order to be helpful, we need to have those numbers. That as part of our job is to present those numbers to the extent we can.
Next slide. So this is from the national expenditures, and it shows the total healthcare spending in a different definition than what the sustainable, as it does include how much a variety of things. And I think that Charlie has given you some references to the methodology, but it is primarily based off of census data and a variety of economic indices, and is extrapolated forward depending on when the various data sources were available. So it's not direct from the payers, as is the sustainable cost growth data, which is on the next slide. So according to the state, who's collecting this data directly from the payers, we have increased our spending from 6.1 from 2021 to 2022 as we were coming out of the pandemic. The largest area, the blue is the commercial line, the orange is the Medicare, the gray is Medicaid, and then the net cost, some of the data, it's the difference between the what they collected in premiums and what went out to pay for services is in the gold color. And then the other are, and we'll see it on the next slide, a variety of other payments to other entities, such as the Oregon State Hospital, et cetera. And the largest spend is Medicare at this and currently. Next slide. If you went per person, it's about 9,261 per person for a year in overall expenditures from the 2022. There is a 180-day lag before they ask the payers to submit this data in order to make sure that all the claims have been adjudicated, and it is based off of the negotiated price that is actually being paid. So it's the allowable costs. National average in 2022 was 13,493. Again, that's from the expenditure data, so it's slightly different, but Oregon has been over the years much more efficient in its care, so it's not surprising that it is lower. But there are a lot of nuances in there that I would leave to actuarial experts to explain further to you once your consultant team gets on board for the project. Next slide.
And I believe Charlie has a question.
Oh, yes, Charlie?
Yeah, I mean, there's a couple of reasons it's different. One is that the national average is actually total healthcare expenditures. So it does include public health. It does include expenditures on structures and equipment. Another comment is that if you actually multiply that 9261 by the Oregon population, you get a number that's quite a bit larger than what is reported on the previous slide for total healthcare expenditures in Oregon. And another thing that's going on is, as I pointed out, there's a lot missing. And that's one of the things that at some point, it would be really nice for us to be able to talk with OHA and work with them to get good data and to find out what their estimate of what's missing is, because they may have some pretty decent estimates of that. So, and yes, it's extraordinarily surprising that the number is that different. I disagree with you that you said it's not surprising, it's different. It's extraordinary, because if you actually look at data over time, Oregon health expenditures are pretty close to national average by almost any measure.
And the cost growth does admit that it captures about 90% because of some of the limitations in what they can collect. So that's also a contributing factor here too. Next slide. Oh, Laurel.
Yeah, I just want to offer and reaffirm what Janine has said, which is that OHA has worked pretty closely with HMA on this presentation, and a lot of the sources that Janine's pulling from are actually from, as she said, the cost growth target team. So happy to check in further, but we're also just wanting to kind of reaffirm for you that there has already been that collaboration.
What I'm looking for is collaboration between OHA and us, the committee members, so that we can actually do the work that we need to do. Thank you.
Next slide. So using the data the state has been collecting, the total healthcare expenditures by market has gone up and down, as you can see, with the per person per year dropping significantly during the pandemic, which would be expected due to the lack of utilization. Next slide. So the program looks at their data they collect also just zones in on the total medical spend, which is a subset of the total healthcare spending that is from their data sets. And it was approximately 8,000 per person per year. It's based off of the claims and non-claims. Non-claims includes value-based payments for healthcare. The all-payer database is another database that has a lot of data in it, but it doesn't tell you what you're being paid if you're paying outside of that, such as in capitation payments or value-based payments. So when they're asking their reporter, the mandatory reporters to submit data, they're asking for not only what was spent on in terms of claims, but also what they're paying for value-based payments. And as the country and the state is moving more and more to value-based payment, that allows more information about where the dollars are going. Next slide. It then breaks it down. They also ask them to break it down by where they're spending it, and there's details galore in the 88-page document that I read recently on terms of where to put it, in what category and why. And this was all determined by technical advisory work groups working with the OHA in developing this. And so it is broken out by hospital inpatient, outpatient, professional services, which actually is further divided into primary care and specialty care. If you look at how they actually submit the data, long-term care, retail pharmacy, and other, such as rebates and other things. Other things are included in that. And the rebates being primarily on the commercial side. The Medicaid program submits their information as well. Charlie?
Unmute, Charlie.
Oh, thank you. I want to point out that on this slide, if you look at hospital inpatient and outpatient, the total is about 10, and this is in 2022, the total is 10.8 billion. And if you actually look, OHA requires hospitals to report data to them. And if you look at the detailed hospital data bank from OHA for 2022, you find that the total net patient revenue in 2022 is 15.6 billion, which is a lot larger than 10.8 billion. So that gives us an idea of how much is missing from this cost growth target data. So that's among the things that we need to work on and work through. And OHA has a lot of really good data, and it would be great to be able to work with them on getting the decent information for us. Thank you.
And well, this is the data that the hospital systems are being held accountable for. This again is the medical expense, so it does not include the other data.
The hospital reporting data is medical expenses either. I'm just trying to give an idea of how much is missing. And I don't know, it's probably a lot to do with the fact that there's a whole lot of mandatory, a whole lot of people paying for hospital care that are not mandatory reporters. But I don't know that for sure, and that's among the things we need to decide. And in fact, if we're going to have a universal system, we need to try to figure out what all of the expenditures are, not just the ones from the mandatory reporters that put into the cost growth target data, which is why my whole feeling is that this is not useful data to us for what we need to do. It's for a different purpose.
Okay, so we're going to have a discussion about that, about what baseline data would help us, what's missing from the cost growth data. So we want to get through a few of these slides. Thanks.
Next slide. They also break it down in terms of by major line of business, statewide, commercial, Medicare Advantage, and Medicaid. And it shows some growth overall and some of the areas where the growth is. And non-claims, again, is payment for, and you'll see the Medicare Advantage is quite high. Some of that is due to value-based payment adoption, and also the Medicare pays the plans directly, who then pay their, there's more detail within their report in terms of that. Next slide. So other healthcare spending is included in their analysis. It includes the growth in behavioral health contracts that are outside of regular claims, primarily in mental health and substance use disorder, treatment and recovery. A lot of these tax dollars began to flow due to passage of Measure 110, originally passed in 2020, and that those dollars have started to come out and be used. And it's had a drug treatment and recovery fund during 2021 and 2022. Next slide. They also included the pharmacy purchasing program. I'm sure that John fondly remembers the origins of this from our days at the Office of Health Policy, but it is currently a discount card program to help lower out-of-pocket costs for individuals. It's a joint purchasing effort between the states of Nevada, Washington, and Connecticut with Oregon, and it allows savings up to 80% and on generics and 20% on prescription, and free to any resident. The other healthcare spending line that they track is the Department of Corrections, Veterans Affairs, and the Oregon State Hospital. Next slide. So there has been past modeling. Everybody has the challenge of figuring out exactly what to put into that. And defining the expenditures that helps to lead to examining the funding sources for those that may be available or not as you move forward into the Universal Health Plan. According to the Sustainable Growth Program, what is being paid to providers now is approximately $9,000 per person per year. And the majority of that is spent on their actual medical expenditures, either through claims or through the value-based payment non-claims approach. PCPCH payments to the primary care clinics is included in that non-claims. And if you pull out the administrative component of that, that averages around $8,000 with the data that is currently being secured from 30 payers across the straight reporting across all their lines of business. That includes CCOs as well as commercial health plan. So the question, and I'll turn it over to Cheryl to take it for here, is this a potential starting point, and what could be included and what could be excluded, and what is leave this for your discussion at this point before we move on to revenue, where the money comes from.
Okay, thanks, Janine. I'd like to open it up to discussion. So what we're trying to get to is a consensus on total health spending and land on a starting point. So the option here is starting with 34.7 billion as the total healthcare expenditures. is there something that should be removed from that total? And we'll either do a vote after this discussion or maybe the fist to 5 to see like how close we are on using this as a starting point. So that's where I welcome any discussion, any questions or suggestions about taking things away from that total. Yeah, go ahead, Charlie.
So I would suggest that we find out a way that we can work with OHA, with DCBS, with SAFE, with what other state agencies or entities, and also other public entities to try to get appropriate data. And to do this not in a meeting, but between meetings. And we probably need to have another, we maybe at this point can discuss what sort of thing we should have. And my feeling in general is that we should keep all healthcare expenditures that we can identify, current healthcare expenditures that we can identify, and we should have a data stream of hopefully from maybe 2019 through 2023, so we have some chance of trying to decipher what's COVID related and what's not, et cetera. And we can maybe begin an extrapolation from that, that we can decide what doesn't need to be included for purposes of the plan we want, but it would be nice to have as complete a data as we can get so we can compare it to known sources. We adopted at our last meeting, we adopted some attributes that we should have, and among those was being able to compare to known sources. So I would suggest that we figure out how it is that we are going to interact with OHA and DCBS and other entities so that we can get the data we need.
Okay, let me pull apart those questions and I'll probably put Laurel on the spot here. Hi, Laurel. So you're looking for, and I agree with you on this, the 2019 through 23 data to the extent that we can get that data. And I think a lot of things happened during the pandemic that would be very informative to us. And it's really a different world. I can say that for the behavioral health system for sure. And then you want additional sources of data. And so I would be interested in hearing from OHA on what those might be. You also asked for potentially meetings in between our committee meetings. And I hear what you're saying. I think I'd be open to scheduling another committee meeting, just to remind you that with public meeting laws, it's not like we can just get together informally and we can't meet as a quorum either. So we'd either have to schedule a committee meeting or a few people talk amongst themselves. That said, I feel like if OHA has more data to share and more sources, I think we all should hear that same information too. So Laurel, could you speak to any of those things?
Yeah, I think just going first to the request to somehow have these conversations behind closed doors. I just want to reiterate what Cheryl said, that we're really committed to transparency as an agency. It's one of our values in our strategic goals. So all conversations about this are going to be part of public meetings. And we would absolutely welcome if you wanted to share some type of list of data that you think is not included in this presentation. We'd be happy to kind of go line by line through that list of data points and see what is and isn't possible.
Thanks, and just really quick, a follow-up. How possible is it to get data post, 2019 to as current as 2023? Is that going to be possible for us?
It depends on the data source. I mean, a lot of what Janine shared is actually post-COVID.
Yeah, that's right.
Janine, do you want to speak a little bit more to that as
well,
well?
I looked, the current data call was September 6th. So the next round of data coming out from those reporters is will be January the rest from 22 to 23.
Okay.
So we will then, the state will have all the data because they started collecting 18, 19, on. So they've got quite from this source of data. They also are very familiar with what's in the national data sets, and could have a conversation about the pros and cons and what's feasible. But again, that other national data set comes from a variety of national sources, of which many are economic analysis and economic bureaus and census. This is actual data that's collected here in the state, and again, a unique opportunity for your state. And I know Charlie does not agree with this, but it is, having worked in Washington and other states and their cost board, they're trying to get as good a data as Oregon has. Massachusetts uses them as a model. It's incredibly impressive what Oregon is doing with this program when you look at it from a national perspective. So.
And I just really quickly, and I'm sorry, Richard, then we'll really get to your question.
Yeah.
I just want to talk a little bit about process. We have these committee meetings to have the committee have a conversation about what the committee wants to see as in next steps. And so, Charlie, you've made some great suggestions that should be a discussion for the committee. And if there are additional pieces of information that OHA can provide, then we will work with OHA. They're on the team. Health Management Associates is on the team. DCBS is on the team. So the idea of all of the resources and staff that we have is to provide the information to the team, to the committee, and to work for the committee. And what I want to make sure that the committee and the staff is responsive to what the committee's asking for. And what we need to make sure, because we do have a lot of capacity and we've been bringing on more with Health Management Associates, and we have Laurel and Devlin and Jessica and Danielle now at OHA. So we've got more capacity than we've had in the past, which is really exciting. But we need to make sure that it's not just each individual member requesting information, that it's the committee that's coming in, that it's a collective request from the committee. So that's why we wanted to make sure it was a part of this conversation and this discussion about what the committee wants to do in terms of next steps. So thanks. Sorry about that.
Morgan, really appreciate all your help and OHAs, HMAs to help us kind of get through this very complicated set of tasks. So appreciate you all. Richard.
Yeah, the Universal Health Plan represents by far the largest public spending program that Oregon's ever seen. And I think it behooves us to be absolute masters of the data. And the way I visualize it is, if the national framework, the NHEA, National Health Expenditure Accounts, has an approach, I think it's incumbent on us to take a look at their approach and say, how does Oregon fit with that, and be curious about where there might be differences or where there might be. I don't think it's a matter that people are not submitting good data. I think the data are good, but they're just different categorizations and they're maybe missing data. I ideally see us as being curious about that. We're looking at massive public spending, massive tax increases. And so we need to have the numbers. And I don't think that digging in to the numbers has to be something that's not transparent. So I would foresee several members of this committee in a working group with HMA and with OHA and with DCBS to go have a back and forth, as you're seeing on this committee, have a back and forth to say, well, how about this and how about that? And why couldn't we have that on a public Zoom? I mean, it doesn't need to be Robert's Rules of Order. It's just a working group, but the public's always there in the background. So I don't see a conflict between getting answering all these questions and being curious about why there's a differences in categorization accounting and the public's right to know. I am firmly committed to transparency, and I want to make sure that we do the best job we can for Oregonians. Over.
Seems like a good approach to me. John?
Yep. I agree with what Richard just said, and I think that's the way to proceed and do it in public and frankly check all the boxes. One of the more demanding, I think, requirements, if I understand, is we should be making every effort for our decisions to be a consensus. And I think Charlie has set a good standard in terms of his approach and his document. Our job is to keep working on that until, as a committee, we're at consensus, which is unanimity. I'm prepared to make whatever commitment is necessary to do that. These are really incredibly tricky numbers. My sense, for example, is that hole in the cost growth reimbursement or cost growth database, that hole involving self-insured employers, is a big one. From conversations I've had with insurers, many of them virtually, but certainly the majority of employers are self-insured. All the big ones are self-insured. I believe a majority of commercially insured patients are self-insured. And I know that was, a guess, if you will, an educated guess on the part of optimists. We need to sort that out. So I think it's important to figure this out, and I would be concerned that the difference may be around self-insured employers. I also think that it's useful to know what the whole pie looks like and where those dollars are, and where the funding for each of those comes from. Just one other concern. I do have some concern about what's going on in Medicare Advantage. I think there's national and some local concerns about what's going on at Medicare Advantage. And when I saw that the numbers around the non-claims expenditures, I can't help but think, I got to understand this a little bit better, because that's going to be key. Oregon is heavily into Medicare Advantage, and where those dollars are going and how they're reported, and all this is important. So that's where I'm at.
Thanks, John. So you're in favor of forming a work group that meets in a public meeting space to not only dig into other sources of data, but some of these specific things like Medicare Advantage that you mentioned? Yes.
I mean, at the top of that should be resolving the discrepancies that Charlie has identified. I feel like a responsibility, I mean, I've been around these numbers a lot, but they're complicated numbers, and I think Charlie's concerns are bona fide, and to get this off to a credible start, we need to do our best to resolve committee member concerns.
Okay, thanks, John. Charlie?
And I want to just emphasize one of the things that John mentioned, and that's about self-insured. So DCBS provides detailed enrollment information and include self-insured as part of that. So if you look at the ratio of self-insured to commercial insurance, and by commercial insurance, I mean small group, large group, individual, student plans, and ATM, which is associations and the MEWA and whatever else, I forget what all is in there. But if you look at the ratio, in 2015, that ratio was 75%. So it means that self-insured was only 75% of the rest of commercial. By 2019, it was 100%. By 2023, the most, maybe it's even 2024 data, the most recent data from DCBS, it's 125%. So there's been a huge increase in self-insured, which is probably why there is quite a bit missing from the cost growth target data. And we, again, need the best data we can get. So among the things that I'm going to request, and however we make these requests, is that we get a little bit more complete enrollment data from DCBS, and I can specify the particulars that are not readily publicly available. Most of it's publicly available, but not all of it. And so there's a few things that I would like to see, and I can make that particular request at some point.
Thanks, Charlie. Just to pause for a second, Morgan, do you know that is something that you can get from DCBS, or would you need to look into that?
I'd need to look into it. I think that coming to some clarity around what information the committee is requesting by the end of this meeting, and then we can meet with OHA and HMA and talk to DCBS about what we can get by the next meeting and bring it to the next meeting, or if the committee wants to add an extra meeting. In our current policies and procedures, there's work groups can be made from the governance board, but we don't have a process for committee meetings. So I would just be interested in who would want to be a part of that, because maybe it would be easy to just add another meeting in a couple of weeks and see how much information we're able to collect.
Yeah.
And so we had kind of plan for a meeting in 2 weeks in between the next regularly scheduled meeting.
That's exactly where I was going, and I assume you three, John, Richard, Charlie, want to be involved in that meeting. I would be curious to know whether other committee members would like to participate too. I mean, of course, you'd be invited, and then that becomes our work group in between meetings, whoever is able to attend and wants to. But I agree with you, Morgan, that we need the very specific questions we are looking to find answers to by the end of this meeting, so we can mull this over and get through the rest of Janine's presentation, and then just let's come up with that list of questions. You can be thinking about it as we go along. John?
Yeah, just one quick comment. I mean, listening to Charlie's comments about self-insured, going back, remember that slide where one of our responsibilities is to engage or enable the engagement folks to be to talk to employers, small and large, self-insured and commercially insured, I would assume. And really, those folks are going to be very skeptical, and they're going to know their stuff. And you know, so this is a group we better be prepared to spend the time and rigor to know as much about what their situation is as we possibly can. And also, you know, my sense is the major shift, if you will, in financing this is going to come with replacing employer contributions. And so from a tax point of view, you know, this is where the tax expenditure is going to come from. The folks who are insured through employers and shifting that burden from their employers to them and the rest of us. So this is a topic we really got to be on top of.
Yes, very good point.
I just wanted to add that some of the mandatory reporters are the third-party administrators who operate those self-insured plans. So they do have that, the third-party administrators are reporting data into the Sustainable Cost Growth Program.
And it would be great if we could get that data separated out. that's terrific, Janine. And you know, I mean, PEB is self-insured, and I think OEB is self-insured.
Yeah, and it includes PEB, OEB, federal employees. All that data is in this data.
Yeah.
So
Well, that's helpful. So at least we'll have some.
it's not, except that the it's self-insured is more voluntary, and there's a whole lot of criteria over who's mandatory, who's voluntary. It's not perfect. As I said, it's about 90% is what the program thinks. But again, can certainly have those conversations.
Yeah, I mean, PEB and OEB, public employers aren't covered by ERISA. So
Right.
we have a different set of challenges with them. But hearing that information, that makes me feel that we're going to understand them to some degree before we engage with them. So thanks for that.
Before I get to Charlie, I do want to give other committee members the opportunity to chime in on this discussion. If you would like to, just raise your hand. What do you think about this? Are you in agreement that we need to have a meeting between meetings? Would you be willing to participate? I'm reading the room that we're not ready to vote on this 34.7 billion as a starting point. Is that correct? Okay, we need more information. So I'm just going to put that aside unless Janine or Morgan, you have another option for us. So we'll continue talking about this, but I do want to hear from other committee members. Would you be willing to let us know? Let me see. How about Jeff? What do you think about this idea to meet between meetings and have a specific set of questions, potential other sources of data, so forth?
Yes.
Yes? Okay. Any other comments you'd like to make on this?
No.
No. Okay. How about Sam?
I agree we need to do more work on the spending data. I would definitely be interested in doing a meeting between meetings. I think I still have some unanswered questions too, especially around, this is based on present spending. But, Cheryl, as you know, in cases of the behavioral health system, we have historically underspent on a whole part of our care continuum. And so that gives me a lot of heartburn that we are taking for granted that the status quo is what we're solving for.
Right.
And I'm not sure that that's wise. But I would also just caution this committee, we all want to come up with a cost target that we feel good about. And we're going to have to be okay with unanswered questions, ambiguity, and we kind of have to decide what level of precision are we willing to go towards in order to get through this first milestone. So I'm a little concerned that, we get to this point of just asking questions and not feeling good. But, if anyone in the financing world is familiar with this, there's only so precise we can get within a certain time period. So we need to hold that in our minds. And perhaps one way to work through that is to think of it as a range instead of a very specific dollar amount target. That's one way to go about it. And as we're working through all these questions and thinking we need more precise information about this or that, thinking about the magnitude of that impact. So if we're talking if we have 3 more meetings to get more specific on X part of expenditures, but it only amounts to maybe 300 million up or down, does that really matter at the end of the day when we're talking about billions and billions of dollars that we're trying to work towards? So just some things for this committee to consider.
Yeah, thank you for those comments. And I can tell you, it worries me all the time to use current cost data for behavioral health. So I brought that up a lot with the task force. So thank you for mentioning that too. Did I miss any committee members, Katie, that I didn't call on? I'm sorry. There are a lot of
we did
people
have Bethany join us a little while ago.
Okay, Bethany, care to share your
I
opinion?
don't have, I really appreciate what she just said, and I mean, I'm willing to meet in addition, because I don't think it's a good idea to base it on current spend, so more info would be great.
Okay, great. Thanks, Bethany. So Charlie,
At what, maybe you can remind me at what point in this meeting it would be useful to make a motion of a particular data request, because you said something about that we need to, as a committee, decide what the requests are. And I have some particular requests that I already know I would like to make, and I would expect the committee would say yes, and it would be a quick discussion. So at what point should we do that?
yeah, I'm not sure if we need to vote on it or not, if we just have kind of verbal consensus, yeah, that sounds right. But I'm gonna defer to Morgan to see if if we actually need to vote on that list of things we're asking.
I don't think you need to vote, but I would allow, like, if there's any discussion about it, and just
Yeah.
kind of make sure that the committee is kind of like in general agreement. Yeah.
Uh-huh, okay, sure.
And
Let's
so
see.
at what point should we talk about those particular items then?
Yeah, I would say we're getting close to our break, and I know some people like
Okay.
me, we need a little bit of time to process things and, mull it over and think about potential questions. So that'll give us a little bit of time to think about it. I don't know, do we want to go into these other questions really quick? Like, are we going to include Department of Corrections, Veterans Affairs, State Hospital in the total expenditures? Some of these other questions, or if there are other major expenditures that we should be including, we could address those questions if that's something we can talk about now, right before break, and then just think about the other things we'd like information on, the data sources and things like that, for this in-between meeting. And then we'll get through Janine's other slides, and then we'll talk about that, and let's just generate a list. That's how I see it. Jeff?
Just, I want to reinforce Samantha's comment on, particularly with respect to the projections we'll be dealing with. We will be better served by being what I call vaguely right versus precisely wrong.
Okay. Thanks, Jeff. John?
On mute. You're on mute, John.
Oh, yeah, I'm sorry. I would like to just quickly go to those other questions. For example, I would not differ from the task force recommendations on the Department of Corrections, Veterans Affairs, and State Hospital. We could probably spend the rest of the morning talking about each of those, but
Yeah.
I think staying with the task force, the recommendation is prudent now. Since the task force, there's been additional public funds allocated to behavioral health, and so certainly that should be included. And it's good to see that that spending is increasing. And likewise, I would think the prescription drug program should be included for that reason. And that's where I'm at on those questions.
Okay, thanks, John. Richard, do you have opinions about these questions too?
Yeah, I think that in the interest of mastery, that we should have a long spreadsheet of every dollar that's spent on healthcare in Oregon, and be able to tie it to national accounts and all the rest. Then we can have a check mark about whether it's going to be covered and paid for by the universal health plan. So that, for example, Veterans Health, I don't think we're going to be intercepting the payments from the feds for the veteran. So I don't think it should be part of the accounting of, I don't think it should be part of the payments of the universal health plan in Oregon, but I think we should have accounting and know what it is. Again, it's just mastery of the data. The more we understand about what's going on in Oregon, the more likely we respond to changes in the environment. So I think we should get numbers for it, but no, I don't think it should be part of the taxes that people pay, because we're not going to interrupt the stream between the feds and the care provider in the VA hospital. That's
Yeah.
my opinion.
That sounds like, that makes a lot of sense to me. Is there general agreement on this, or does anyone have a different viewpoint? Both what John talked about and also Richard. Okay, I'm just going to assume we're all okay with those suggestions unless anyone says something differently. Okay, so I believe we are at break. We have a 10-minute break. Oh, Jeff, did you want to say something real quick?
Yeah, just as a more for understanding, I agree on the comments on the Veterans Affairs, but with respect to the Department of Corrections and the state hospital, if there are dollars that are directly under state control, and we are talking universal health plan, to whatever extent those dollars are under Oregon's control, they ought to be included.
Well, the Oregon State Hospital is almost completely reliant on state general funds, I can tell you that.
So, I mean,
So yeah,
I'm willing to be persuaded otherwise, but it strikes me if it's entirely reliant on Oregon, then those dollars ought to be included.
yeah, we should tease that out a little bit. And to Richard's point, if we get the costs of all those expenditures and the sources of the funding, maybe that will be clear to us then when we see this. So I think that's a good idea. I do have one lingering question for Charlie that I'd like to, probably near the end after Janine's slides. I want to understand what you all include in public health, because I'm not sure that I understand what you're talking about, because public health is huge, and public health has a lot of responsibilities that aren't necessarily they're not necessarily like related to a person's individual health. They're more like population based, and so I just want to dig into that a little bit if we have time to. So that's just a lingering question for you. So with that, I want to give you your 10 minutes or so, and we'll get back in 10 minutes, and then I would like to hand it back over to Janine to finish her presentation, and then we'll have more time for discussion. So thank you. Take a break. Hi all, we're coming back from our break and I'd like to give Janine the floor to finish her presentation. And then we'll dig into those details on the questions that we would like to ask and do some planning for that in-between meeting. So Janine?
You ready to go? Okay,
Yeah.
next slide, please. So the state does a regular Oregon Health Insurance Survey that tells us where people are getting their current coverage. And this is the pie chart. I think we corrected, Richard, what was a typo. It's on your original, the 12.9% are covered by Medicare, which is the gray. OHP covers 32%, commercial 46%. There are still 3% uninsured, and 5.3 are self-insured in the sense that they are paying for their own insurance without an insurance. So that's different than self-insured plans, just to be clear. Next slide. So this is from the cost growth program, tells you the total expenses by the different components we talked about earlier, the percent change, and what was included in each of those. Next slide. So Medicaid is a joint funding between federal and state government. We have currently the current the last biennium. I picked the 2021-2023 biennium here, just so you could kind of see how it relates as close as possible to the 2022 data you were being shown. But for every dollar Oregon spends, the federal government matches about 1.46. So we get more money than we actually put in, so it's not entirely 50-50. And the general fund dollars come from general taxpayer, or the general fund as it is called, and which includes cigarette tax revenue. And it also includes some healthcare provider taxes. I will talk a little bit more about that. Next slide. So there are other programs besides the basic health that are part of the Medicaid funding we get. There is a Healthier Oregon program that just got started, where immigration status no longer affects whether someone qualifies for OHP. The federal government doesn't allow coverage for this, but Oregon is paying for this. It's only for the state dollars are in this, and it is just, as I said, just coming up, and it has the dollars there, about 563 million for the 2 years was what was in the most recent legislative budget. There's also the new, what Oregon calls a bridge plan, or what nationally is a basic health plan. It uses a particular section of the Affordable Care Act to get dollars. It helps bridge that time between where people fall off of the OHP based on their income, but are not necessarily able to afford other types of insurance. The goal is it will eventually cover about 100,000 people. There was dollars budgeted in this, which includes both state and federal dollars. And the majority of these enrollees were on OHP, and then during the pandemic, as you might remember, they were allowed to stay without having redetermination of their income. And so the bulk of the folks that have moved over were those that were falling off of OHP. And so the expenditures in 2022 are these same people that are currently on the bridge plan. Next. The provider tax allows the state to use some money to bring in additional total Medicaid funding. There are hospital assessments, include both large and some rural hospitals. There's assessments on health insurance plans, and there are long-term care nursing home assessments. About 30% of the state sources for OHP are derived from the healthcare provider taxes, and not all of the provider taxes are dedicated just to the Oregon Health Plan. The long-term facility tax offsets some general fund expenditures for nursing facility services, independent of OHP, and some provider taxes have been used for hospital quality improvement and health incentive purposes. And this is based off of current information from the Legislative Revenue Office. And currently we collect approximately $1 billion, 1,097 million collected from the 3 provider tax assessments. Cigarette taxes, excise taxes are imposed on distribution of all types of tobacco products in Oregon. It's about $3 per pack of 20 cigarettes. There's $2 per container of the other tobacco product and $1 per cigar. We have some of the highest rates on cigarette taxes in the country. And then they are distributed several ways, and there's a dedicated amount that goes to the OHP. And there's a new, and then there's an allotment that goes to mental health services outside of OHP. Next slide. So moving to commercial insurance, there is non-group and group coverage. So non-group is a self-insured in the sense that the person is purchasing the insurance directly via a broker or through the insurance exchange, or what we call here in Oregon the marketplace. The individual pays the full premium cost unless they qualify for any premium assistance through the marketplace. Group coverage is what is offered by a sponsor. So that can be an employer, such as the PEB buys group coverage for all state employees and university employees, a union or a trade association. The employer contributes to the premium and the individual contributes as well. In addition to its the employer contributes, its contribution is not considered income, so under the federal income tax code, so it's not subject to taxation to the employee. Employer contributions are tax deductible as a business expense for the employer. The individual's contribution is the premium contribution. It's usually pulled out of our paychecks for those still employed. And then there's cost sharing on top of that, depending on the structure of the benefit plan, co-pays, co-insurance, and deductibles. And those are only paid when you use services of the plan. Charlie has a question?
Yeah, so on the individual contribution, is the individual contribution to an employer plan subject to FICA taxes?
I don't know for sure on that, but we can.
Thank you.
Yeah. So this is also data from the Oregon, from the OHA. The individual, single, and family plan premiums have continued to rise, and you'll see that in the diagram. The green is the family plan. The single, if you're just one person having insurance, is the blue line. They have started to decrease somewhat in 2022 after a fairly significant rise over the past decade. And on average, employees pay approximately 20% of the premium and their employers pay the rest, but it varies by the employer, industry, and size of the company. And to show that, I put in how the various types of industries like agricultural, fish, forestry, and construction might be paying more of that overall total premium cost as opposed to, and retail as well, versus maybe more professional service categories would be paying less. And then it also varies by size of company. If you're a large company, then you're potentially as an employee paying less than if you're a very small company. Next slide. And in 2022, people with commercial insurance paid, based on the data pulled in from market trends, found, and there's a whole report on this that the OHA has. They paid about 776 on average in cost sharing, or about 13.6% of the total cost of care. The majority was spent on deductibles, coinsurance, and co-pays. This is captured in the Sustainable Growth Curve expenditures because that is required by the mandatory payers to include that. But I wanted to show here how it breaks down. Next slide. And cost sharing there is a deductible is one of the ways that the individual is contributing to their cost of care. Most people in Oregon with a commercial insurance plan have a deductible, but how much they pay for that, how much they're obligated to pay, varies by plan. There has been an increasing movement over the last decade or so of moving to what's called a high deductible plan. It's where there's a significant deductible they need to pay before the health plan kicks in and pays for things. In 2022, the minimum is about $1,400 for the individual, $2,800 for family coverage on average. Those plans often have lower premiums, which is attractive to person looking at their monthly costs, but they do have that higher deductible to have to meet. They can create health savings account associated with these high deductible plans with pre-tax dollars before that get pulled out of their salaries before taxes are applied, and they can use that to cover that care until they reach that deductible. PEB and OWEB are the benefit programs for state and school district employees, respectively. In addition to medical and dental coverage and vision, these programs offer other benefits to their employees, including life, accident, disability, long-term care, and flexible spending accounts. They also offer insurance options for retirees not yet eligible for Medicare. And in the case of and sometimes also have a group Medicare plans. PEB is state funded. OWEB is funded by the participating school districts. A portion of the premium are paid by the employees, along with the cost sharing, similar to what we just discussed about the general commercial plans. The amount the state will contribute to the PEB benefits is negotiated as part of labor contracts with the state employees. And similarly, the Oregon Educators Board, the amount they pay depends on the negotiated labor contracts with the teachers and the staff. These two programs together are just a little under 300,000 people in Oregon, because it includes the employees as well as their families. Medicare funding, which is it's a federal health insurance program. It's for all people over age 65 or people with long-term disabilities. Just under 1 million Oregonians are enrolled. People can choose to get their Medicare benefits either through traditional Medicare and or these newer Medicare Advantage plans. In Oregon, approximately 51% are in traditional Medicare, and then 59% have either a Medicare Advantage plan or other plan versions, so that can include Medigap, et cetera. So those don't total up to 100% for that reason, because some of the people who have traditional Medicare have an extra plan to cover some of the expenses not covered by Medicare, and that is the Medigap. Medicare is complex in the sense that they have multiple parts. Originally, when it was passed, it was mainly focused on hospital costs. So Part A is the hospital and stays and skilled nursing and home health care. Part B is what is actually where a lot of the expenditures in Medicare are these days, because it covers outpatient services such as provider visits, outpatient hospital care, and preventive services. Part C is the Medicare Advantage program that allows Medicare beneficiaries to enroll in a private plan that covers Part A, B, and D. And D is the voluntary outpatient prescription drug benefit. Funding for Medicare comes from federal general revenues, which primarily finance Part D, payroll tax revenues from both employers and employees, which primarily finance Part A, and premiums paid by beneficiaries, which are income adjusted, used primarily for Part B, plus the cost sharing requirements for the individual. Part C, Medicare Advantage funds are drawn from the funds that go to Part A, the funds that go to Part B, and then the MA plan enrollees pay their Part B premiums and may pay additional premium if required by the plan. But in 2023, 73% don't necessarily need to pay extra. Next slide. So this is just a different way of kind of looking at the revenue sources that go into Medicare. The general revenue, payroll taxes, premiums, taxation of Social Security benefits, and payments from states, interest, and other revenue. And this is from the Kaiser Family Foundation's most recent look using the data from the Board of Trustees for Medicare. Excuse me. So cost sharing for people with Medicare Advantage is somewhat similar to that of commercial in that they pay co-pays, co-insurance, and deductibles. They paid about $985 on average in cost sharing, or 9.1% of the total cost of care. Most of it was in the form of co-pays. And the average co-insurance was about 32% of that, while the average amount of deductible paid was $45, or 4.6% of that. Next slide. It's difficult to fully capture all the contributions by Medicare enrollees in the traditional fee-for-service in Oregon. Per the OHA's look at this, many people purchase these Medigap plans and Part D plans to avoid being exposed to the high cost sharing burden. So some of this is derived. They have a whole paper on this to describe approximately where the dollars go in terms of what is being paid for Medicare Part B portion of it, any additional premiums, any supplemental insurance, which you can see there ranges quite variably and from $27 to $944, depending on if they're just buying a Part D plan or if they're buying other types of Medigap plans. Next slide. I guess we're at the end. Next slide. So getting back to the takeaways, the enrollees in commercial and Medicare contribute significant amounts via cost sharing, and the system is financed through a mix of household, employer, state, and federal funding. And I think the discussion slide follows this. And this just outlines again that the assumptions from the task force, they assumed that the Medicaid dollars from the state general fund and the allotted portions of the cigarette tax devoted to the OHP plus the federal match would most likely be able to move forward, but most likely the provider tax revenue would not. The Medicare dollars, they assumed could go forward. Again, challenging, but potentially. Other states have used their universal health care plan as more of a wraparound rather than trying to get those dollars, but the task force wanted to include those. And then state investments such as community behavioral health. Charlie, you have a question?
Yeah, or maybe more a comment related to Medicaid. So one of the things that we need to be aware of and probably talk about at some point is that the Optimist report assumed in their numbers where they ended up with a net savings of a billion dollars. They assumed that federal Medicaid dollars would increase because more people would be essentially enrolled in Medicaid. But I think we need to be wary of making that assumption because the waivers, most of the waivers that we think we might need or be able to get include a notion of not increasing the federal deficit. So basically not increasing the amount of dollars that come. And so I think it'd be tough to assume that we could actually get more money when we apply for a waiver for Medicaid than we currently get. And so that brings up a couple things. One is it would be really useful to make a big effort to try to enroll people in Medicaid now who are eligible but unenrolled. And just think about this in the future that I really doubt that we can get extra money from them. So.
And also just to qualify that was prior to that basic health plan or the bridge plan, which is a way to have brought in some federal Medicaid dollars. So Cheryl, I turn it over to you.
I'd be curious to know if any of you have different assumptions to consider. Do you agree with these assumptions by the task force? Before we move on to the questions that we have, the list we're generating. Go ahead, John.
Yeah, I think there was discussion at the task force. I don't think the task force wanted to take away the enrollment and administration in Medicare. In other words, my recollection is that, I mean, that would be a very difficult and expensive task to take that away. And so Janine, I think the task force was actually more around a wraparound approach like you've described, to let the feds enroll people, collect A and B, report that to the state, and then those folks would be enrolled in the Oregon version of single payer Medicare because of the administrative costs.
Yeah, it's just the way it's worded is a little different than say what the Green Mountain Board had, where it was really you got A and B and it was more like a Medigap versus it sounded like the task force wanted to take the dollars that were submitted for A and B and then use it to pay for UHP. Does that make sense?
Yeah, and now actually thinking about this, in some respects, I think some of us felt, well, however Medicare Advantage is being administered,
okay,
that's what the single payer should want. And I think Medicare Advantage, again, in the feds enroll people, determine eligibility, collect A and B within Social Security. Oh my gosh, we would never want to, change that, I don't think.
So more like the MA plan rather than, okay.
Yeah.
That's what I was meant here was the federal and individual contributions, but not necessarily the administrative overhead.
Yeah, I mean, I have a variety of other comments because I think these slides are very rich in terms of issues we're going to need to figure out. For example, provider taxes. I don't see how the single payer could justify, off the top of my head, a provider tax, which the hospital would then expect the single payer to pay them. You know what I mean? It goes over as a cost on the hospital or provider side. That doesn't seem, to make sense. So that would need to be sorted out. I would mention though, on the other side of that, the hospitals are no longer going to have health insurance costs to pay for most of their employees, assuming most are residents, and so that cost will disappear on a favorable side. So I have a variety of other comments, but I'll hold them.
Thanks, John. And I know we're running into the time, and we have something extra to talk about. So I think we'll get Charlie's question, comment, and Anya, and then we'll wrap that up and just talk about our questions for our in-between meeting. Go ahead, Charlie.
The task force actually proposed 3 possibilities for Medicare to be considered. And one was a wraparound. One was actually getting a waiver and taking it over. And another was for the state to become a Medicare Advantage provider. So just want to clarify that.
Yeah, thanks for clarifying that. And I do wonder, if we're trying to get everybody to be close to, PEB benefits, let's say that's where we're starting. What do we do with the lack of coverage in Medicare for vision, dental, not great coverage for behavioral health and vision? I mean, that's a very real gap in Medicare. So Anya, I thought I saw your hand raised. Do you want to?
Yeah, and what I was going to say is very consistent with what you just said. I think it's important to separate out at least 2 critical assumptions, decisions about Medicare. One is how is it administered? And the other is what's the level of benefits? And are you bringing that level of benefits up to whatever you're assuming is guaranteed for the rest of the population, or leaving it as is? So you could have a Medicare Advantage-like system with the current level of benefits that are in Medicare, or you could have a Medicare Advantage-like system that provided a higher level of benefits. And I think it's important to just keep those separate.
Yeah, such a good clarification. Thank you. So I'd like to move on to the questions or the list that we have to try to tackle in this in-between meeting. And I think there are questions about data sources and also the data elements we want to tease out, if I'm not mistaken. And then I don't know if we can work on scheduling that next meeting here, or if that would just be too complicated with the 7 or maybe 10 of us who would need to be there. I first though want to thank Janine for the presentation. Sorry, I got ahead of myself. I'm just looking at the time. Thank you for all this information, and I fully expect we'll be working together in between and seeing if we can identify other data sources and get more information on the data elements. So with that, could we start generating that list for this in-between meeting, so we can get that down and just see what OHA, DCBS, HMA can help us with before we get there. Go ahead, Charlie.
So I've got a couple particular requests that I know of already, and one is getting more complete OEB and PEB data. I know that OHA should be able to get that pretty readily. And I put into my public comment the particulars that I think would be useful for that. Another is, and this is both a question and a comment, I can provide quite a bit of data, and my question is, if I'm going to provide this to the committee, do I have to submit as a public comment, or what's the best way to provide some of this data? And then another particular request from DCBS. So there is public data available that I've collected from DCBS on enrollment by quarter and from 2015 through 2020, June of 2024 for ATM, which is associations, trusts, and multiple employer welfare arrangements, small group, large group, individual, student plans, separately self-insured. And there's also data available for a few particular points on stop loss only, short-term medical, TRICARE, other Fed, Medicare Advantage, Medicare HMO, and Medicare Supplement. that data, as far as I can tell, is only available for a few quarters, some recent ones. It would be good to have that data for, I'm sure DCBS has it, and if they could provide that for 2015 through 2024, or even just 2019 through 2024, that would be, I think, very useful. There's also there's CAC, which is Cover All Kids, and HOP data for, which is a Healthier Oregon plan, I think it is, for undocumented residents of Oregon. And that data is publicly available through CCO financial statements for 2022, but it did not seem to be there in 2023, and I'm sure OHA has that, and it'd be nice for them to be able to provide that as well. What are the expenditures in those programs? And it's actually just the CCO part is what's publicly available, and there's probably a little bit of fee for service in there as well, so that should be included. And again, OHA should be easily able to get that information. DCBS also provides data on for each insurance company of what are their earned premiums, the written premiums, and their losses, the amount they actually pay out. And I think DCBS would be able to sort that out into various categories of, is that for a Medicare Advantage insurance? They certainly could do it for most of the commercial insurance, for the Medicaid CCOs. And so it seems like there's a lot of data that they have that would be useful to us, that if they could sort of sort through it and collate it in a particular ways that we can talk more about, would be very useful. So I'll stop there.
So Charlie, a lot of those things you identified in your public comment, right? So we could just dig those out, or are you adding new things? And if that's
There's a few new things which I can provide, but most of those.
Yeah, and to your question about how you provide those questions or those requests, I don't think you would have to provide it through public comment, but the information will be posted to the public. But I want to make sure I'm not wrong. So Morgan, could you clarify or confirm what I just said?
Yeah, I think if Charlie has a document that he wants to share, he can send that to committee members.
Okay.
And when there is back and forth between members, that's when you get into an unnoticed public meeting. So it's best to use the BCC function to share, so there's not that deliberation, but sharing information. And then if it's information that you're sharing, I think we would want to make it publicly available and post it as materials for the meeting so that it can be shared. So yeah.
Does that make sense?
Yeah, and I guess we should talk about a little bit about the data that I present. I guess since I would want some feedback on it before, to make it better for our usage, I guess we might have to do that in a public meeting or something. But anyway, I can provide the data. So thank you.
Okay, thanks, Charlie. Richard.
The way I see this process rolling out is not just going to be a single in-between meeting. This is an ongoing study and discussion group, and there's a lot of back and forth that I expect. And I think that I think Charlie's public document that was already submitted is a great place to start, because it lists out all the places to look. And again, it's not the saying that here's good data and here's bad data. No, the idea is we're curious about why there's a difference in categorization and what else can we look to support our plan. And so I would foresee a back and forth exchange of documents among this work group members, and that we come to each meeting having already read all the material. So no one's responsible for preparing a PowerPoint. It's like a study group. You read the material, then you come to the group and start talking about it right away, get right into the list of questions and what is still, can we check this one off? Like comments in a Word document. Someone says, do this, have we addressed that or not? And that more documents would come before the next meeting and we progress like a study group. So that's how I visualize it. Thank you.
Yeah, and I didn't mean to imply that we were only going to have this one-off meeting, but it's just a starting point. So we'll see where we get, with this in-between meeting. So that's fine. And we can talk more about the process of how we share the documents. John?
Yeah, actually, there's an item that I don't think came up in either the slides or our discussion, and that's reserves and profits. I think that it would be good to have some sense of to what degree our revenues going into a reserve fund, or going in the case of a for-profits into profits, which are then distributed to the investors. I mean, this has become a big issue. I mean, it was surprising to see that Care Oregon had $1.3 billion in reserves and had accumulated a significant portion of those reserves during COVID. I know, and I don't fully understand this, but I know there was a process at OHA where they decided, well, to what degree are we going to allow the for-profit CCOs to take a chunk of money and distribute it to their investors. So I think to fully understand where the money's going, I think those reserves and profits are something we should eventually look at. Maybe not,
Yeah.
but put those on a to-do list.
I know the reserves is on the list of tasks. I know it's not, you can't see it here, but it is on the list of tasks. So I don't know about profits though. So that's worth talking about when we talk about reserves, I think.
And just to pipe in, I think
Go ahead, Mark.
the reserves that are currently on the work plan are about what the universal health plan would need in reserves. So
Right.
it's a little bit of a different
Little
issue than
different.
John is bringing up.
Yeah, that's right.
Yeah, I was intrigued. I can't remember where I read it. I think, there's some discussion going on related to the legacy OHSU transaction, and especially the legacy transaction to form a foundation. And in one of those discussions, a participant said that when Kaiser took over group health in Washington, group health was a nonprofit, so it needed to create to give away all the excess funds it had at the time that it went over to Kaiser. A $2 billion foundation was created. All the insurers I've ever been involved with are carrying reserves. Those are usually, generated conservatively. DCBS makes sure that folks are adequately reserved. And so how that process works is going to be important to us. It gets back to your issue, Morgan, which is the case, but also to the revenue issue. Thanks.
Definitely agree. Thanks, John. Laurel?
Yes, thank you. I was just wanting to make sure that I'm capturing the asks, and I just realized that there's probably going to be more asks coming up. So maybe I'll hold until the end, and then let's make sure to reserve some time so that we can have some back and forth to make sure that we're accurately capturing kind of next steps here.
Okay, thanks, Laurel.
Yeah.
And Richard, let you have the last word, although I want to go to our quiet committee members, make sure you have an opportunity if you have any questions too. So go ahead, Richard.
So one thing that Charlie brought up was, I think, facilities and equipment. And what I'm asking about is, what about capital expenditures? For example, if a hospital wants to build a new hospital, part of that is fundraising, but part of that is just operational reserves. Not, I don't want to use reserve, the margin that they've accrued on previous operations. To what degree is capital spending, for example, something that would be depreciated over 23 or 30 years or whatever? To what part of that is part of the budgeting? Because if we're going to have a universal healthcare plan in Oregon, we got to account for how we build new facilities, inpatient, outpatient, whatever, to cover it. And so are we including what would otherwise be considered capital expenditures as part of the universal health plan? I'm not saying we should or shouldn't, but we need to account for that so we're not double counting money that a hospital gets as part of its payment for services, but they take some of that margin to build a new hospital. Over.
Yes, really important aspect, and that can be super expensive too. So I want to just check in with Sam and Bethany. If you have anything to add, questions, or, data elements that you'd like to include.
Yeah, a few thoughts. First, yeah, I agree with John. I would like to see more on the reserves needed. That was actually one of my priority questions from last time, and I think that was a recommendation in the report to work with the Division of Financial Regulation to assist in thinking about that number. Plus one to Richard's comment on having more of a study group, documents back and forth and comments. It can be difficult to hold a lot of this in between meetings anyhow. So I really like that as a process idea. Per my comment before, if we can try to chip away at that question of future expenditures and not just looking at, what's the current spending, but especially trying to look at where we underspending in our system and might need to bump that up in the future. Very specifically, and this is something we could get our heads around more easily, is how do we account for the aging population in terms of impacts on future expenditures? And then finally, I think a lot about private pay, just outright private pay. Kind of thinking about Richard's idea of a full accounting of healthcare spending in the state. It would be very cool if we could have a line item, even if it's not something that the health plan would cover, to try to estimate how much healthcare is actually being funded by private pay. I don't know that that's a very easy question to answer. In fact, I don't know that anyone has answered that yet, at least not in the state of Oregon, but I am personally very interested in that.
Great additions. Thanks, Sam. So with that, I know we're a little past time. I just want to make sure I understand the process in between the meetings, that will be okay. That we share documents with the group to the general email that Morgan mentioned, the DCBS email, is that correct? And that we just need to be careful about not responding, providing feedback back and forth as a group, is that right? But we'll be able to look at the documents, and then do we provide any comments by email? I mean, can we do that to the person who sent the document? Can we do that kind of thing? Ask a question, a clarifying question? Or do we just read them and be ready to talk about them at our next public meeting?
Yeah. So these are really good questions and a really good conversation about how this committee will operate. And, I think that what you saw in the committee decision piece that Cheryl went over was a different model, kind of like a staff presents proposals, discussion, refinement of the committee. And what I'm hearing is you want more back and forth. And I would like to suggest that Cheryl and I have a little bit of offline conversation and just figure out like the best way to facilitate that within the current public meetings law, and wanting to, I am hearing from the committee that everybody wants to be transparent and figure out a good process to allow that transparency and the need to review documents in between. So I'd like to chat with Cheryl and kind of come back to the next meeting. I also want to say, I'm glad to get clarity on the requests from the committee, and we have capacity, and there are a lot of requests, and I want to make sure that they're all kind of in line with this first task on this process that we're looking at, that's reviewing the current health spending. And then I heard some other suggestions that we could pause on those requests while we focus the committee on the first part of the process.
Is the question, Morgan, whether, I'm not sure if I understand the question, but are we still asking, are you going to like sort out the questions by whether it gets to the health spending? Is that what you're saying? And then the other questions get deferred to when we're talking about those things? Is that what
Yeah. Yeah,
okay,
for example,
got it.
I think John
Okay.
was just asking
Yeah,
about
yeah.
reserves,
Yeah.
and
Right.
that's an interesting discussion for the committee to have, but
Yeah.
we've kind of put that into the phase 2 conversation. And so I would like to make sure that we're able to focus our capacity on
Yeah.
the data requests that are getting to this kind of
Yeah.
first step in the process.
Very understandable. So it's almost like in a parking lot, and we'll get to it next phase. Yeah, got it. I know we want to make sure that we clarify the questions for OHA and others. I do know we also have another agenda item, and I'm pretty behind. I hate to give short shrift to the, the revenue guiding document, the principles, attributes. On the other hand, I think it's really important for us to get to the heart of the work here, and this was really important to kind of flesh this out. Not only what we need in terms of sources of data, but how the process of sharing that data and how we tease those things out. So I think that was really important. So I can certainly go fast with the guiding document, and we have been through this before. We're just looking at it in a bit of a different way and suggesting, I think we have a recommendation for you on how we kind of close the loop on the principles and attributes, because we want to move on to, to the strategies and getting the work done for the main objectives of this committee. So is that okay, Morgan? And then we go back to the list and clarify, or what do you think?
Yeah, the only thing that I think that's a good process. I think the only thing that I would clarify is that I think Charlie mentioned earlier that the committee kind of adopted the attributes of a sound financial plan at the last meeting. And I don't think that the committee, I think that Chair George asked for some feedback, and my sense was that there wasn't a consensus. So this is I also heard, as we reviewed at the beginning of the meeting, that there was a suggestion to kind of put the revenue principles and the attributes into one document. So we got some suggestions that we wanted the committee to think about. So this is kind of an agenda item that's trying to close the loop on some of the conversations that were had at the first meeting, and get clarity about those two documents that were reviewed.
So with that, I'm going to go speedy quick and just cut to the chase. So we didn't get a whole lot of discussion or concerns on the principles. There was a suggestion on the equity principle, and we showed you that the board has already approved the equity value. It's very much based on OHA's equity goals, so it'll look familiar. So one question is, do you still want something specific, a specific principle on equity in, as far as the revenue principle? So that's one question that we wanted to finalize.
Cheryl, are you able to pull up the equity value that was approved by the board?
I'm not, but maybe Morgan or Katie might. I don't think we have that in our.
It is posted on our website, and the board adopted the health equity definition that OHA adopted.
It was from the Health Equity Committee.
Yeah.
I believe that's the name of that committee. Yeah. Are we showing that or no?
Yes, I'm going to pull it up.
Oh, okay. Thanks, Katie. So here it is. Did we get to the bottom? Oh yeah, there it is, yeah. This is the detail on the health equity principle.
Okay, thank you. Yes, I'm familiar with that one.
Okay, you are.
Of course, I better be by now. Yeah, I think my brain just, it immediately goes to process and, you know, thinking about how do we apply that across these committees? Really, what does that look like? And, you know, at baseline, I think about when we're looking at the economic impacts, for example, making sure that we're looking for all those different populations, what the impacts could be. So maybe that's not a right now question to answer, but I would just encourage the board and the committees when it comes to those processes of looking at health equity impacts to have a shared framework and process for doing that.
Yeah, absolutely. Let's keep reminding ourselves. And I think that's also where we tried to get to with targeted universalism too. So, okay, John.
Yeah, I'm sorry about this, but you know, I was around on the 5 years of this definition, and I'm sad to say that this definition that was just put up doesn't include a couple of elements that I think are key to the OHA definition. The OHA definition has language like A and B, but then has 2 bullets that specifically emphasize focusing on historical injustice. And then a second bullet about the importance of the transfer of power and resources. And I've expressed concerns at HICMO that despite their public statement that they follow OHA's definition, when you look in their rules, it's a different definition and they exclude those 2 bullets. And to be consistent, I would just like to ask that you look at the definition that's on the Equity Committee's webpage, and specifically those 2 bullets, and make sure that those 2 bullets are included. Some of the wording under B1, I think it is, or talk about the distribution of power. Well, distribution of resources and powers. So that one probably is okay, but there's no mention of historical injustice. And I would appreciate you looking at that. Because in my mind, this one is not consistent with the Equity Committee's definition of health equity.
Okay. Morgan, would this go back to the board then? Or this question? Or this recommendation?
I mean, I think there's 2 things. One, updating the values and principles that the board adopted would go back to the board.
Mhm.
And 2, I think that the suggestion or kind of discussion here is if there's an equity principle that the committee would like to emphasize in the revenue principles, or in some guiding document. So, if the recommendation is to update this definition with the OHA definition, then that would go to the board. And if it is to use OHA's equity definition for revenue discussion, then it would be a conversation here.
Okay. I'm trying to think what to do next. Does anyone have a suggestion on whether we should add something more formally to an equity principle? I know you were mentioning, Sam, that we just need to be intentional when we're doing this work to ensure that equity is incorporated, but you know, having heard from John, should we actually add something more formal into the principles on equity? I'm gonna ask Sam first and then I'll call on Charlie.
I might want to give that some thought because I mean,
Okay.
for me, it's how detailed do we want to get into the application of the equity principle in our principles document or values
Mhm.
document?
Right.
So I would like to give that more thought if
Yeah,
that's right.
okay, me too. Thanks, Sam. Charlie?
I would just say that when I read B1, there is at least a little mention of rectifying historical and contemporary injustices. I'm not sure if that's sufficient, but it is there. And so,
Mhm.
yeah, thank you.
Okay. Thanks, Charlie. Okay, can we go back to our slides and then we'll move forward here? Okay, so as Morgan said, there was a recommendation that we could, or suggestion that we could potentially combine the principles and attributes documents together. And Morgan and I were giving that some thought, so let's just go to the next slide real quick. So these are the principles. I'm not going to read through them, but this is what we had discussed, and it seemed like I don't think we had any issues with these principles. At least they didn't come up. So I don't know if anybody would like to had a question or a suggestion on the principles. Go ahead, Charlie.
So I think I put this in a comment to an email to you that one of the principles or things we need to be considering is federal tax expenditures. The fact that when we're trying to design a revenue system, the fact that employer contributions to employee health plans are not subject to federal taxes, either income or FICA. Changing that could make a big difference in how much taxes Oregonians pay. But I mean, that was sort of taken into account in the task force, and so that's part of why they did the employer payroll tax. But it's something we need to be aware of.
Okay, is there a way that you would articulate that as a principle?
Yeah. Think about or be cognizant of or have some plan for federal tax expenditures. Let's say so. Consider federal tax expenditures might be sufficient.
Okay. Any other thoughts on this particular edition? Just because we don't have a whole lot of time. Oh, go ahead, John.
Just one issue that I've been struggling with, and that's what about expenses that currently are funded by a tax stream, but may not be easy to access. I mean, let me give you an example. PEB is currently funded by the state and the state general fund. One would hope that that funding could be moved over to the single payer and not be part of an additional tax that would be created. It gets trickier when you look at OEB, and OEB is funded by taxes. Every year I pay property tax, and there on my property tax is an assessment for the schools. And the schools are paying into OEB. From a revenue point of view, it would seem fair that because of this shift in taxes, that funding stream could be accessed and continued somehow. Do you follow me?
Yes, yeah.
And, you know, when you then look at the counties, the cities,
Mhm.
there's a lot of healthcare being funded by tax streams that, you know, could reduce, frankly, the need for, quote, new taxes.
Mhm.
You know, that
Yeah, sure.
that's what the point I'm trying to make.
Yeah. And I wonder, we don't have time, but if you could articulate that as a principle, I think we're gonna have to look at this again because we just are running out of time. So if you could do that in between, that'd be great. Sam?
I think as a principle, I also add, what do we do with any savings that we achieve in this program? Does it stay captured in, for example, a trust fund? Does it go back to the taxpayers of Oregon, et cetera? But that I think should be a part of a revenue plan as well.
Okay, thank you. I do want to quickly get to the attributes recommendation that we have for you today. And, I would have liked to close the loop on the principles, but I appreciate the thinking and adding important other principles. So I don't want to just force us to, to go with what we've got. So we're just going to probably have to come back to it again. So, oh yeah, we had some other additional principles too. I'm just trying to figure out how to manage time right now. I think since we have other principles that you've articulated today, why don't we add this to the list and then we'll go through these possible additional principles together. I would say, if not, probably at next month's meeting, I think we'll have to pick that back up. But I do want to get very quickly here we go. This is what we wanted to recommend to you. We feel like we have 3 ways to go on the attributes document. We could either combine them with the principles. We could potentially pull out some of the attributes and make them principles or sub-principles, or we could use the attributes document to guide discussion during specific topics. For example, healthcare expenditures during the healthcare spending topic. So we wanted to ask if you have a preference. Personally, I would recommend the third option. That's where I want to go, but I certainly want to see if we have consensus on that first before we move on from the attributes document, because we did spend a lot of time on the attributes last meeting. So trying to close the loop on some of these things. Any quick thoughts? Want to make sure we also have time for public comment. Being none, I'm not sure. I suppose we'll have to loop back to this in December and just know that the third option is my recommendation. And then you will just have to let me know your preferences. And if it would be helpful, we can send, the attributes document back out too, with the additional principles that we're considering adding. So maybe we just finish that all up in December. So with that, I do want to make sure that OHA, DCBS have the HMA have the clarity they need on the questions, and wanted to give them the opportunity to ask questions back to those of you who were suggesting, other data sources and things like that. So, Laurel, did you want to ask any questions? Make sure that the request is that you understand the requests.
Yeah. Yes, and I do worry that at this point we'll see what we can do here. We'll see if we can land
2 weeks.
Land these. Yeah.
Yeah.
And Morgan, did you want to go first with kind of DCBS?
No, I've
Okay.
been taking notes. And I think that what we'll need to do is put all of the information to all of the requests together and get as much information together as we can. You know, some of these may take longer, but we'll compare notes and make sure that we've got them, and we'll talk about what we have at the next meeting.
Yeah, I like that approach. In other words, I mean, I'll say right off the bat, there's a few things that I heard that are not going to be things that we're going to be able to do, and there's others that there's some more nuance, and would love to dig into, like, kind of trying to find the right, you know, spot of granularity. And then there's others that it's like, yes, absolutely, we can do that. So there's really a range in some of the requests that I heard, and I think maybe what I'm hearing from you, Morgan, is that a good approach might be just to like repeat back the list that we heard, and then we can follow up with kind of where each of those requests land on that spectrum. Is that what you're thinking? Yeah.
Sure.
Yeah. Okay.
Yeah, that sounds good to me too. And I would just encourage any of the committee members, if you have additional requests or you think of additional data sources, data elements, the ways to tease out the data, just please let Morgan know. And you know, we will have this running list, and if you also want to further define your request, that's fine too, in between. I don't think we should try to schedule the meeting right now. But I'm just guessing, I mean, we're assuming that we'll meet in 2 weeks, and we just need to find a good time and day. And I don't know if that will be exactly 2 weeks from today, or if we're gonna need to find another day. I guess it just depends on our availability. So I don't know if that will be done by a doodle poll or what, but.
I think that Katie will reach out,
Okay.
and she is our scheduling guru, and she will work her magic and find a time. Yes.
Yeah, I would look to do a series of meetings, not just one meeting.
Mhm.
And if you miss any one meeting, the ideal is that you have the information coming into your inbox all the time to digest, so that even if you can't be present at a given meeting, you're still part of understanding the data that are coming across and can participate in the discussion.
Yeah, I think we'll want to kind of poll everybody and ask everybody their availability. But I'm not comfortable just scheduling a whole bunch of meetings that are going to take a lot of staff time without knowing that folks can attend. It will take some time to pull this information together. And so I do think we should look and maybe schedule in between meetings, like one in between November and December and one in between December and January, so that we have them on the calendar and can have that. And Cheryl and I are going to talk about other opportunities to comply with kind of a transparent approach and have the back and forth that you're looking for, Richard. I'm hearing what you're asking for, and I want to like make sure that we have enough time in between meetings to get the committee members good new information to be looking at.
Yeah, that sounds good to me too, Morgan. So with that, does anyone have any additional reflections to share? I was really glad that we had such good discussion, and you've shared a lot of your thoughts, and I think we're working on a good process moving forward. So sounds good to me, but does anyone else have any last minute reflections before we turn it over to public comment?
Yeah, I do. I think I very much appreciate the presentation by Janine, covered a lot of things. Well, there's so much feedback from this group that I would say assigning that presentation to be read and studied before the meeting. And then you come to the meeting ready to go, say, on slide 32. Does anybody have questions on slide 33? So that instead of having, again, Janine did a great job, but in general for this committee, I think instead of spending 50% on presentation or 60% on presentation, spend most of the time just looking for questions and responses to it as opposed to presentation. So that,
Yeah.
especially when our time together is limited. Assume that you've read it, you've studied, and you've taken notes. Say, I want to ask about slide 32, and go through it in an organized way, but avoid the presentation. Not that I want to avoid Janine's contribution. It was great, but spend the time on discussion, not on presentation. That's what I would say.
We probably did more discussion than originally planned, let's say. But appreciate that. So with that, it is 11:50 and it's time for public comment. I believe we at least have one person who's going to do public comment. Is that right, Katie?
Yes, we have Tom Sinsick signed up today.
Okay, is Tom with us? I can't see all the boxes.
Yes, take it away, Tom.
Hi, Tom Sinsick, a retired family nurse practitioner. Thank you for your time. Very excited about here that there was more time on discussion than presentation, and that there was pushback on the word total, which should be eliminated from this thing. I think it's very important that you think about your equity principle first and compare everything you decide against that. And I don't hear that. And also the issue of coming from a scarcity framework. There is no evidence that there's scarcity. We're spending too much, more than other countries. So kind of keep away from the scarcity framework. I think the recommendations, which was in my note, you need a spreadsheet with a list, right? And you're going to start filling in the list, which is the expenditures. That was my idea about the student health expenditures. But, and then John saying taxes. Now how does the HR work that's managing those student counts go into a tax fund, right? So that was one thing. How much money are people spending traveling out of the state or out of the country on healthcare, right? That's an expenditure. You might not be able to get the information, but these things should be added up on the list. The students, in case of the student one, it's hundreds of millions of dollars, right? And it's inequitable in my documentation. The system is inequitable. So that has to be remedied as this kind of goes forward. And there's just a list that I would like to know, right? The cost of a strike, right? Strikes are costly, and many of them are based on getting access to healthcare. That's an expenditure that comes into play. It should be listed. Might not get the answer, but you know that there's a lot of gaps. So I think getting with that is, and I would also, just since you presented the principles thing at the end, the attributes. It is too early for this group to decide whether how a vote will be taken care of. That's the work of advocates. Your work is to push forward the best plan, and the legislative process will decide about what might pass. Not in the context of this group. So I would remove that as an attribute. So how would I, at the end, if I find out, as we're engaging the public all the time, how would I put in like, hey, please add this to your spreadsheet without going through a whole public comment piece? Because people are telling me all the time where money is being spent and wasted in the system. It'd be good to know, where I could just, since I'm primarily doing public engagement, talking to people all the time about this. So I guess that's it. So
yeah, thanks, Tom, for your advocacy. I really appreciate you. I don't know the answer to the question you just asked. I'm going to defer to Morgan because I'm not sure how you would provide suggestions, recommendations without going through public comment. So Morgan, do you have an answer to that?
Yeah, I think that this will be the work of the committee to figure this out. I think I hesitate about just opening up a spreadsheet and having people add things to it that haven't been talked about in the committee. What we want to make sure we're doing is not double counting. And some of the suggestions that I've heard are kind of already captured in other parts that might be included. So I think that that's why we have a committee here and making sure that there are discussion pieces. I think that that's why we have a process of submitting public comment at least 72 hours before the meeting, so that it can be in enough time for committee members to receive it, to start to digest it, and to make sure that it's those points can be a part of the conversation during the meeting.
May I just add one thing? Thank you for your work. It's very great, the conversation. And you do have an ERISA expert on another committee. I hope people are paying attention to Jim McGee, and then you bring him maybe if it's needed to present to your committee.
Yeah, I noticed that.
He is the master of the ERISA world.
For sure. Thanks, Tom. Okay, with that, so I guess one thing we didn't do is next steps really quick. So we are going to schedule a couple of extra meetings so far. I mean, I see the point about scheduling a bunch of them, but we'll start with a few. We are going to continue to gather the questions or recommendations for data collection and disaggregation, I would say. Then OHA, DCBS consultants will work on trying to get that information for you, or they may have some questions for you on those requests at our next meeting. Did I miss anything, Morgan?
Well, I think just you and I are going to talk about kind of like how to facilitate a process that has regular engagement with the committee and is still making sure that it's transparent for the folks who are watching this process closely.
Okay, thanks, Morgan. And anything else for the good of the order before we adjourn? Thank you all. Really appreciate all the work you're putting into this committee. It's such important work. So have a nice rest of the day. We're adjourned.
Bye-bye.
Wishing everyone a happy Thanksgiving.
Yes, happy
Likewise.
Thanksgiving, everybody. Hope you have some downtime.